something that we do every day. It's about the gallbladder ultrasound. Every one of us do several gallbladder ultrasounds on daily basis. The idea behind that is that there are some things that some of us might think are correct information, while in fact they are misconceptions. They are not correct. So just to correct everything in a very rapid and short 20 minutes, I hope. So let's start. For the first thing, the first misconceptions. Some of us might think that gallstones are found only in adults. This is totally wrong. Gallstones can be found in all age groups. For example, you can see here, there is a, I don't know whether okay, just the pointer. For example, you can see here thick sludge with many tiny stones seen in a neonate. This was a neonate, okay? And you can see here, this is a 12-year-old boy with hereditary spherocytosis having multiple gallbladder stones. So they can be found in any age, not only in adults. Another misconception is that some of us might think that it takes some time for gallstones to develop, and this is not correct. The correct thing is that the fact gallstones can develop in a short time, and they can also sometimes disappear. For example, you can see here, this is cephalosporin or claforan induced pseudolithiasis of the gallbladder in a neonate during the treatment. This was a neonate treated by claforan, and within few days he developed all this large and thick gallbladder stones, and when they stopped the treatment, this was his gallbladder. They totally disappeared. It turns back to normal gallbladder. Okay. Another misconception is that gallstones are always hyperechoic structures causing acoustic shadowing. This is incorrect. The fact is that the size and the composition of the gallstones determine their ultrasound characteristics. For example, you can see here there is a sludge or maybe small stones here. They are hyperechoic but no shadow at all. Okay, another example, much more obvious, the gallbladder is filled with stones, totally, completely filled with stones, but there is zero acoustic shadowing. So it's not always, it must have acoustic shadowing. Another thing is that some might think that a hyperechoic mass in the gallbladder region is always a large stone, while in fact calcification can be localized in the wall of the gallbladder, and we should be aware of the air in the gallbladder. Also, the duodenum should not be mistaken for a pathological gallbladder. For example, you can see here, this is not a big stone filling the gallbladder. This is a porcelain gallbladder, calcified gallbladder wall. The entire gallbladder wall is calcified, and here we don't see what's called the wall echo shadow. Try it. We should see what's called the wall, then echo, then shadow. This is a gallbladder, while here we just see a calcification, no echo and no shadow. This is porcelain gallbladder, while here you can see there is a wall, then echo, then shadow. This is a large stone completely filling the gallbladder, not a porcelain. So this we should be careful about. Another thing is that a non-moving mass without acoustic shadowing in the gallbladder is a polyp or tumor, while in fact, this is of course a misconception. In fact, tumefactive bile or sludge can mimic a soft tissue mass in the gallbladder, but if there is a flow, it is definitely not a sludge. For example, you can see here, this looks like a mass in the gallbladder. It's hyperechoic, it's not immobile, okay? While on the CT scan for the same patient done, you can see it's just thick sludge filling the gallbladder. So it's not always everything that's hyperechoic without shadow and doesn't move, it's a mass. It can be thick sludge. While if you see flow within the lesion, it's definitely not a sludge, it's a mass. Okay, another example here, you can see it looks like a mass here, but when we put Doppler, you can see flow within it, indicating a large gallbladder polyp or a vascularized polypoid mass. Not all polypoid lesions are polyps. Keep that in mind. For example, if you look at this liver, you can see there is a hypoechoic mass here, a hypoechoic mass here. These are metastases in the liver, and in the gallbladder you can see there is a hyperechoic mass with vascularity inside. This was not a polyp, this was a metastasis to the gallbladder, like the metastasis in the liver. While in this example, this case, you can see a large gallbladder stone with acoustic shadowing, and you can see a polyp or a polypoid mass also in the gallbladder that is vascularized, and when it's operated, it turned out to be gallbladder carcinoma. Okay. Another misconception is that color Doppler signal in a mass always indicate flow in a blood vessel. This is not correct. Small crystals, small cholesterol crystals, and calcification can cause what's called twinkling artifact, and it gives you a Doppler signal, but it's an artifact. It's not a real vascular flow in the artery. For example, you can see here, this looks like a mass, and when we put Doppler signal, we have Doppler signal, but it doesn't follow the course of an artery. It's just a twinkling artifact. How to confirm that? You just put spectrum on it, and you will not get any pulse in the Doppler signal. You got just noise because it's twinkling artifact. Another thing we have to correct is that thickened gallbladder wall means that there is cholecystitis. This is not correct. There are many causes of thickened gallbladder wall other than cholecystitis. For example, you can see here, this is a thick edematous gallbladder wall. However, there is no stones, no sludge, no nothing, no pericholecystic edema. So this is typical. We see it a lot of times. Indicates what? Hepatitis. Exactly. Thank you. This is a very common finding in hepatitis. Okay. Another example. This was infectious mononucleosis. You can see the gallbladder wall is thick and edematous, and it looks like cholecystitis, but there is no stones, no signs of inflammation at all. Also, the clinical presentation is not in favor of cholecystitis. Another example here, you can see this thick gallbladder wall in this patient with renal and heart failure. And after treatment of the renal and heart failure, this was the result. The gallbladder returned completely back to normal. Also, thickened gallbladder wall is very common finding in patients with ascites. You need to be careful of that. If there is ascites, thickened gallbladder wall, this is just normal, it's acceptable. Another misconception is that gallstones are always found in the lowest part of the gallbladder because their specific gravity is higher than that of bile. This is not correct. The correct thing is that gallstones can have higher or lower specific gravity. They can be floating or dependent, depending on their composition. For example, you can see here, this gallbladder is floating within the this stone is floating within the gallbladder, while these stones are sinking within the gallbladder. It depends on their specific gravity. They can be floating or sinking or in the dependent position. Again, another gallbladder, you can see multiple stones. Some are floating, some are dependent, depending on their weight and their specific gravity. Okay. A layer of floating gallstones must not be confused with emphysematous cholecystitis. Keep in mind, emphysematous cholecystitis means air within the wall of the gallbladder or within the lumen of the gallbladder. Air will be floating always. But it appears like that. It's like an ill-defined shadows with some not very big acoustic shadowing. These are just air bubbles within the gallbladder lumen, and you can see a stone in the neck of the gallbladder. So it can be also air bubbles. Air bubbles might be also introduced by ERCP, by patients who done endoscopy for the papillotomy or something like that. You can see here, this is a porcelain gallbladder. Again, we have calcified gallbladder wall. There is no wall echo shadow triad. Okay, and it should not be also confused with air. Keep that in mind. When you move the patient, it does not move. It stays in the same exact location. Another example you can see here, this is a thick sludge in the gallbladder. A stone is sinking within the sludge, and you have these ill-defined shadows. This is air within the gallbladder. Okay. Another example you can see here, it looks like something in the gallbladder, however, and the patient had a small amount of peritoneal fluid, so he was changed to CT scan, and it was just air in the duodenum overlying the gallbladder, making this shadow maybe a stone, maybe something. So you should be careful of that. Air in the small bowel in the duodenum might also give you this appearance. Another misconception is that air in the gallbladder means there is an emphysematous cholecystitis. No, not always. Air in the gallbladder can be seen after papillotomy, after endoscopy, or choledochoduodenostomy and perforation of the gallbladder to the digestive tract, means ileus, gallbladder, bile stone ileus. For example, you can see here these are multiple air bubbles floating within the gallbladder and within the biliary tree. This patient had a recent ERCP and papillotomy. Another example, you can see the biliary tree within the liver are all filled with air. Patient didn't have an ERCP. What happened? If you look carefully down, there are some small bowel obstruction. If you look more carefully, you can see a large gallbladder stone obstructing the small bowel, leading to gallstone ileus. Okay, and the air entered the gallbladder and the biliary tree through this perforation. To get cholecystitis, a patient must have gallstones. No, that's wrong. There is something called acalculous cholecystitis. It's a serious condition. No gallbladder stones can easily lead to perforation of the gallbladder wall and to biliary peritonitis. For example, this case here, there is nothing within the lumen of the gallbladder, no air, no sludge, no stone, no nothing, but the wall is inflamed and the patient was in ICU, critically ill. The wall was inflamed with pericholecystic edema and right hypochondriac pain and the whole thing. So what to do to this case? Either treat, go for surgery. He's in the ICU, he's not fit for surgery. The best thing to do in this case is to put a stent or a catheter within the gallbladder. I mean percutaneous cholecystostomy. I've tried it several times. It works like a miracle. You just put the catheter in the gallbladder, drain the bile, few days everything goes back to normal, and that's it. No need for surgery. I have several patients done this cholecystostomy thing. It's very simple, very straightforward, very effective. Another example, you can see the gallbladder here is perforated and there is floating membranes within the gallbladder with pericholecystic edema, the whole thing. This was necrotic gallbladder filled with sloughed mucosa and it was acalculous cholecystitis. Also another example of membranous gangrenous cholecystitis, sloughed mucosa filling the gallbladder lumen. A membranous gangrenous cholecystitis must be differentiated from septated gallbladder. Keep that in mind. For example, here you have just few septi within the gallbladder, here and there. Is it sloughed mucosa? Of course not. Why? First of all, clinical presentation. The patient is not ill. Acalculous cholecystitis, patients must be in ICU, like critically ill. There is no pain, no pericholecystic edema, no signs of cholecystitis clinically, I mean. Okay? So, if you see these septations, it's just septated gallbladder. It's nothing. Just send the patient home. Another misconception. A mass around the gallbladder means there is a gallbladder carcinoma. This is not correct. In fact, inflammatory mass can be difficult to differentiate from gallbladder carcinoma. Like you see here, this was a gallbladder carcinoma with gallstones and mass infiltrating the liver. You can see a mass infiltrating the liver and a stone within the gallbladder, and on the CT scan you can see the stone filling the gallbladder with a mass infiltrating the liver. This was a gallbladder carcinoma. However, in a different example, this was very suggestive of a mass, stone filling the gallbladder and something infiltrating the adjacent liver. Biopsy was done and it was cholecystitis. Nothing, no mass, no carcinoma, just cholecystitis. Gallbladder carcinoma can also mimic cholecystitis, filled with sludge. Everyone can, vice versa, exactly. You can have both. For example, you can see here abnormal gallbladder. It was interpreted as cholelithiasis or gallstones and cholecystitis with sludge. Operation done, it was gallbladder carcinoma. You can see the stone here, thick wall, edematous, some pericholecystic edema. Everything looks like cholecystitis. Surgery done, it was gallbladder carcinoma. It's not that easy to differentiate. Again, gallbladder with stones and soft tissue structure that were interpreted as polyps. You can see the stone here and some soft tissue, something here. At operation, it was gallbladder carcinoma. Okay, I'm almost finished. Regarding the misconceptions of bile ducts, dilated bile ducts indicates that there is an obstruction in the duct. It's not always the case. Sometimes there is abnormal variety of diameters of the bile ducts depending on the age of the patient, depending if he has cholecystectomy or not. For example, you can see very dilated common bile duct in patients with cholecystectomy. Another example here, markedly dilated bile duct, and another patient with cholecystectomy. Here you can see dilated common bile duct in patients with choledochal cyst. It's just a choledochal cyst. This is the MRCP of the patient. It's just dilated duct due to choledochal cyst. There's no stones, no tumor, no nothing. Non-dilated duct excludes the presence of a stone. No, you can have a stone and non-dilated biliary duct. For example, this is the CBD, and you can see very obviously a stone here, but normal diameter of the common bile duct. Another misconception is that a gallbladder without stones excludes the presence of bile duct stones. No, you can have a stone in the in the common bile duct, no stone in the gallbladder. Not always. Okay. For example, you can see here this gallbladder very normal, and you look at the common bile duct, it's dilated. You look more carefully, you see a stone within the common bile duct with normal gallbladder. It happens. It's acceptable. Okay. Another example, very normal gallbladder, and you can see at least 2 stones within the common bile duct. Okay. Another misconception is that hyperechoic structure in the bile duct is a bile duct stone, while hypoechoic structure is a tumor. This is not correct. Bile duct stones sometimes are not always hyperechoic, and tumors are sometimes very echogenic. Also, you should be careful for air. For example, you can see here, these are air bubbles within the common bile duct. These are not stones, these are not tumors, just air bubbles. You can see here air in the bile ducts filled with air that looks echogenic with shadow. Someone might mistake it for a stone, and you can see in the CT scan the bile duct is filled with air. Another example here, the bile duct is filled with something echogenic. However, this patient has hemobilia, and by ERCP you can see the clot filling the common bile duct. Okay. Here you can see a pitfall. It's hyperechoic choledochal carcinoma obstructing the bile duct. This was a tumor obstructing the bile duct. It's causing acoustic shadowing. Some might think it's a bile duct stone. It's just a carcinoma of the common bile duct. This is a mass at the liver hilum, which is called Klatskin tumor. Exactly. Klatskin tumor causing intrahepatic biliary tree dilatation, while the extrahepatic bile duct is very normal. Okay? It's not dilated. It's obstructing the biliary tree at the hilum of the liver. While here, you can see cholangiocarcinoma with vascularized tumor mass in the common bile duct with dilation of intra and extrahepatic biliary tree. This is a vascularized mass within the common bile duct obstructing it, causing dilatation of both intra and extrahepatic biliary tree. This is a very typical case of Merizzi syndrome. You have a stone at the neck of the gallbladder obstructing at the level of the cystic duct, obstructing the bile duct, causing intrahepatic biliary tree dilatation. I think the last misconception is cholangitis only caused in the presence of stones. No, this is not correct. You have other causes of cholangitis. Usually can be seen in patients with Crohn's disease or ulcerative colitis without the presence of stone. You can see here, this is a common bile duct stone causing cholangitis. The caliber changes from normal distally to dilatation proximally. Okay. This cholangitis due to stone. However, in this case, there was absolutely no stones. This was sclerosing cholangitis with thickening of the wall of the biliary ducts in patients with long-standing Crohn's disease. Another and the last example is dilated intrahepatic biliary duct caused by primary sclerosing cholangitis in patients with long-standing ulcerative colitis. And this should not be confused with the Klatskin tumor, dilated intrahepatic biliary tree and extrahepatic. Klatskin causes only intrahepatic because it obstructs at the liver hilum. I hope this was helpful in correcting some misconceptions. Thank you very much for having me, and thank you for the nice time. Thank you.
Well, I guess